the state of care in MS is kind of interesting. First of all, MS is the leading edge of neurotherapeutics. Neurology for a long time really didn't have much in the way of therapies, just good diagnosis. And now, starting with MS, but other areas as well, we have multiple agents that alter the course of the disease. This is really exciting, and it's been a little over 25 years now. More recently, we've addressed, in part, one of our major unmet needs, and that was how to deal with progressive MS. And so we have one agent approved for primary progressive MS. We have a second agent which is pending approval for secondary progressive MS. Both of them are breakthroughs because they're first in class, but they're modest, very modest effects. And so one of our big unmet needs would be to have better agents for treating progressive disease, because progressive MS is the form of the disease where people develop the most disability. And so that needs to be worked on. And we have some potential therapies. We're looking for new molecules. We'd like to have more molecules that were strictly neuroprotective rather than just immunomodulatory. And then the next frontier would be repair. So we have early phase studies looking at repairing the damage that's done. This again is a major breakthrough, because if you had asked me 5 years ago, will we be repairing or even thinking seriously about repairing the nervous system, I would have thought unlikely. But the strategies are there. It's a much bigger challenge to design and implement studies looking at repair, but the potential gain is tremendous, because if we can repair the damage done in MS, we can potentially repair the damage done in other neurologic diseases, depending on the strategy that's used. So that has terrific potential. The other thing that we're talking about here at the 4th Annual ACTRIMS Forum is how do we personalize medicine, precision medicine. These terms are not as important as the concept. And one of the things that we lack badly in MS is the ability to individually prognosticate. So I can show you lists of good and bad prognostic factors in MS, but they only hold for groups. And our ability to take a given individual sitting in front of you in the consultation suite and say, okay, your MS is not going to be a big deal, you'll do fine, and someone else say, you worry us a lot because of these indicators, and we're going to treat you more aggressively. So currently, we get to the you worry us a lot, but our ability to predict is not great. And so that's why we're talking here about how do we develop individual prognostic markers, and these could be genetic, they could be fluid biomarkers, they may be MRI, they may even be clinical presentation, or, and we've had discussions, response to an initial therapy. And that will help us address the question that's being debated is, do you start with a very aggressive therapy because MS is a bad disease, it can cause disability, or do you start with what may be a less aggressive, maybe even less effective, but safer therapy, because we know that some people respond just fine to those. And right now we argue about that because we don't have the data to answer the question. So I think that's the major issues in MS right now, is being able to individually prognosticate, and then moving forward, developing better therapies for progressive disease, and then repairing the damage to the nervous system. And then maybe a little farther down the road, we'll figure out how to cure the disease.